We now have 64 patients, 33 with Crohn's, 6 with ulcerative colitis, 22 with IBS, and 3 with microscopic colitis, with the male-female of 30 to 34. Mean duration of treatment is 6 weeks. The overall response rate in our Crohn's, ulcerative colitis, and DIBS, and we can define response or talk more about response during the discussion, is 70%, with clear efficacy signals in the majority of patients, with a mean time to early response of 2 to 3 weeks, with a more significant response usually seen at 6 to 8 weeks. The response can be partial or complete reduction of diarrhea, bloating, and abdominal pain. We've only had 2 AEs, one with nausea and one patient with a short gut with a ileorectal anastomosis, pain and bloating. The conclusion is that whether patients have active mucosal disease or wherever their disease is located in the gut, whether there's a certain phenotype, whether they've had surgery, a number of our patients have had surgery, independent of disease duration, all of these patients in our 66 patient data set, particularly in the Crohn's patient, were, I think, candidates for looking at the opportunity for applying this medical food in these patients. And indeed, the role of using this agent in early phase disease may, if it really restores the mucosal barrier and blocks TNF and tightens tight junctions, may have definite benefit in these patients. The potential for it having an antimicrobial binding property for the CDT patient is interesting to look at. And the immunoregulatory effects on TNF may be of benefit in these patients and may partially explain how and why these patients are responding by restoring normal gut homeostasis. I really think we need properly conducted trials to look at hard endpoints and measurements and biomarkers to understand mechanism of action. Thank you very much.